Hello, and welcome to the recovery training for high-dose corticosteroids. Randomized trials, including recovery, have shown that corticosteroids reduce the risk of death in hypoxic patients with COVID-19, and the current standard of care for these patients now includes corticosteroids at a dose equivalent to 6 mg of dexamethasone daily. We also know that additional immunosuppression with interleukin-6 inhibitors, such as tocilizumab, reduces the risk of death further in patients receiving corticosteroids, but even then mortality remains high. The currently used doses of corticosteroids do not fully saturate glucocorticoid receptors, and it may be that higher doses of corticosteroids could produce additional benefits. However, this could also increase the risk of side effects, such as secondary infections. We do know that higher doses of corticosteroids are used safely for other infectious indications, such as bacterial or TB meningitis. This comparison is open to adults aged 18 and over who are hospitalized with confirmed COVID-19 and require respiratory support with non-invasive ventilation, including CPAP, BiPAP, or high-flow nasal oxygen, invasive mechanical ventilation, or ECMO. It's expected that patients not allocated high-dose corticosteroids will receive current standard-dose corticosteroids as part of standard care, for example dexamethasone 6 mg once daily. Patients with known influenza co-infection are excluded from this comparison, but influenza testing is not mandatory unless for some reason flu is clinically suspected. The comparison is open to pregnant or breastfeeding women, as well as to patients with liver or renal failure. The intervention is dexamethasone 20 mg once daily for 5 days, followed by dexamethasone 10 mg once daily for a further 5 days. Treatment should be continued for 10 days in total, or until discharge, whichever is sooner. Dexamethasone can be given orally, via nasogastric tube, or intravenously, and no dose adjustments required for renal failure. Pregnant or breastfeeding women should receive an equivalent dose of an alternative corticosteroid that's less likely to cross the placenta or be present in milk, such as prednisolone, hydrocortisone, or methylprednisolone, and details of doses for these are in the protocol. General clinicians will be familiar with the common side effects of corticosteroids and should anticipate and manage these as they would normally, for example, monitoring for hypoglycemia in patients with diabetes, or considering gastroprotection in those at risk of ulceration. In summary, corticosteroids are one of the most effective drugs we have to reduce the risk of death in hypoxic patients with COVID-19, but we might not be using them correctly. Higher doses than those currently used could provide greater benefits, but could also be harmful, so further randomized evidence is needed. Thank you for listening.